for this next hour, we are going to talk about health, global health, local capacities of manufacturing of pharmaceuticals, local and global health issues. So for the panel, and I don't know exactly in which order you want or need to talk, we have with us Victor Garcia, who did his PhD in CERMES, in EHESS, and worked on the local, I don't know, like the national capacities of production of medicines, of pharmaceuticals in Colombia. Actually, Victor, I am not sure now where you are, if you have a position in Colombia or in France or somewhere else again.
Non, je suis professeur d'histoire de la médecine à l'université El Bosque à Bogotá.
Ah, c'est ça, in
Donc,
Bogota. OK.
oui. Et maintenant, je suis à Medellín, en fait.
OK. OK. Merci. And so the two other person is Aamod Utpal, who's a PhD student in STS in Université de Paris, and who will talk about the situation as seen from India. I mean, if he reconnects, because as soon as I talked, he disappeared. And the third person is Bertrand Lefebvre, who's a French scholar, a professor in the EHESP, in the École des Hautes Études en Santé publique, and currently guest faculty hosted researcher in Institut Français de Pondichéry. And so I must say that I have a technical issue on my side, which is that I am connected from a phone, and I'm already at 800 megas, and I have only 1 giga. And so I think I will get disconnected before the end of this hour, which is very sad because I would love to hear what you have to say. But I hope I can at least launch the discussion between you guys, because I'm pretty sure you have quite a few things to tell each other. Victor, ça va? Je te vois avancer et pas entendre très bien. The sound is okay? Or...
Pour moi, ça marche.
Okay, good. So yeah, I don't know how you want to start. I think, maybe we can start with Bertrand, who must have a lot to say, not on the pharmaceuticals themselves, but on the health issues in relation to globalization or not.
Hi, Mathieu. Hi, Victor. Hi, everyone. So I decided to focus on the UHC, Universal Health Coverage, because if it's about the past 20, 25 years, trends in terms of global health policies, I think UHC has been really a key driver. And what I will show you and what I will share is basically some of the work I've been doing with some colleagues on basically how UHC is unfolding in one country like India, and how there's a sort of multi-level dimension to it. So it's just going to be a series of snippets, you might say. It's not going to go very deep, but it's more like to enlighten everyone on this. So I will share my screen now, if I can. It's good, yeah. And you see my screen?
Yeah, perfect.
All right. So I'll try to first. Why is it that UHC, was so instrumental and started to occupy, such a center stage, at the global level? It's mostly, as you remember, down to the Millennium Development Goals and the need to basically abate extreme poverty. And one of the issues was basically dealing with the out-of-pocket expenditures. And I just put this chart, from together. And then you look at basically the level of OOPs back in the early 2000s, and then the level of OOPs now. And we look here at basically the trajectory of India, because India was really much at a very high level of OOPs. You see close to 70%, above 70% of the total health expenditures. And slowly, through the years, decades after decades, it got lower. So now we are in a situation where the OOPs represent 50% of the total health expenditures. But if we look at other trends from other countries or other group of countries, you have here the low-income countries, you have here the middle-income countries, you realize that India was really lagging behind and had basically hardly catch up with the rest. And if we look even at other countries like Brazil or Thailand, which in terms of economic development, in terms of, you might say, political, organization, stability, I mean, there are different, dimensions to consider there. And that could, be some interesting points of comparison for India. We see that India is still lagging far behind. So that's just a bit the starting point of my research is that if we talk about UHC, there have been some progress in India. OP's trends are positive, but there is still a long way to go. And you might have seen this cube before. We have seen it in so many publications and reports, including from the WHO on the UHC, because the idea is like if we want to, I'll go quick on this, but if we want to abate OOPs, if we want to improve the coverage of the population, if we want to reduce the OOPs, and if we want to make it in a sort of efficient manner, the cube is a good way to start. It's basically to say we have to improve the coverage of the population, we have to improve the extent of services, health services provided to the population, and we have to do it in a sort of financially sound way. And one way to resolve basically these three dimensions of the cube is to develop insurance coverage and insurance program. And these are two charts looking at basically the percentage of households covered by health insurance in India. And India, as you know, is a very big country. It's the most populated country now on earth. And you have basically a federal system. And hence, it's a shared responsibility between the central government and state union states. And there you see that although there is, of course, this universalization aspiration embedded into the UHC, the progress has been very uneven from one state to another across India. And that you have the black dots you see there are basically the most recent results once it comes to the share of household covered by health insurance. So we see that it has, there's been some progress almost everywhere, but some states, some union states have done better than others. And we can see here Rajasthan, we can see here Andhra Pradesh, we can see here Tamil Nadu, and at the bottom, on the other end, we see Jammu and Kashmir, we see here Uttar Pradesh, we see here Maharashtra, we see here Delhi and Punjab. So it's a very, you see, we have a global objective, we have national policies, there have been all kinds of programs to sort of push forward the health insurance programs. And yet, once it comes to the implementation, once it comes to the reality of these programs, we have sort of strong inequalities from one state to another. One big difference, you'll see this on the right side of the slide, on this other chart, is that the best performing states in terms of coverage are basically the one you see there, the block spot in red, are the one that have relied a lot on government or state insurance program, state-sponsored insurance program. And they have been, in a way, being capable to expand the coverage of their population much further than the states that rely a lot on the national level program that have existed or that are still existing, like the RSBY or the most recent PMJ initiatives. And then you see, it's pretty clear that once we have a push from the government and the local government, we get there, we improve the coverage drastically. And of course, I'm a geographer by training. Also, I didn't do this map. It was in the frame of a publication with Christophe Guilmoto from CEPED, IRD, but I've done also similar map myself. But this map is really showing at the district level, what does it mean now in terms of territorial coverage or territorial inequalities? Who is getting covered and where? And this is where you see a very fragmented pictures. Clearly, some states like here, Rajasthan, have done great for their own population. And for all over the extent of the territory, we have more than 75 or 90% of the household are covered by insurance, health insurance. And then some of the states are lagging behind. So again, we have a national program, national sort of aim and ambition to ensure that there is a universal health coverage, while in reality, it gets very fragmented again. And we can go even closer to the ground realities. It's one thing to say that I'm covering my population, right? In terms of, health insurance and with keeping in mind of, abating the OOPs. And, but how do actually the patients are using the program is also interesting. And this is a work I've been doing with several colleagues, including colleagues at ISI Delhi, Abilu Mukhopadhyay and Pasta Brantra. And we look basically at once patients are using health insurance program, in that case, the Arogya scheme in Andhra Pradesh and Telangana, where do they go for their treatment? How far are the hospitals they are using? And there we see again some inequalities that are coming up. Again, a program that aims to improve and reduce the inequalities is actually not so effective. You can see there on this map, basically, the gap that exists between the distance covered if you were to go to the nearest hospitals in the frame of this program, and actually the hospitals the patients are using. And so the darker it is, the wider is the gap. And it means patients are covering much more distance than expected. And as you know, in India, the more distance you cover, the more cost you are bearing yourself as a patient, because you have to sometimes travel by yourself or with your family or relatives that are accompanying you. And obviously, it's also significant in terms of the geographic barriers that exist. And there's something very counterintuitive on this map, because you see in this, on the coastal Andhra, as we call it, the Delta region, there are a lot of cities equipped with hospitals under this scheme, and yet people are not going there. They prefer to go to Hyderabad hospitals. I'm not showing all the data analysis. And that's, they put themselves in a situation similar to areas like here, or hilly areas, or peripheral areas, where basically people are already traveling a long distance. So there's a sort of dual penalty there. And it should not happen so, because if we look at the millions of claims we have analyzed, the median distance is close to 50 kilometers. It means half of the claims or patients are traveling less than 50 kilometers, and others are traveling more than 50 kilometers. And that's putting the spotlight on one of the weaknesses of all those schemes, which are really about coverage, giving rights. And really much, Mathieu, you have covered those questions, and we discussed it previously with your friend and colleagues from Nepal. A sort of intervention that's not really about physical investments. What we see there is that there is a need to invest in government hospitals or to investment in the infrastructure so that people would cover less distance and would have better access to healthcare facilities. And those type of programs are not really solving it. It's one way to say we are spending now more on health insurance programs are getting used, but it means that you remember the third three-dimension cube. The service coverage is not necessarily improving in that sense, or the last share of the population that we want to cover is not going to be really covered. It's going to be harder to attain this objective. And I will stop there, and thank you for your attention.
Thank you, Bertrand. So I'm just saving a bit my data by closing the thing, but I was listening carefully. I don't know, maybe we could try to have a discussion also. So maybe I'd rather listen to the three of you, if that works, and save the discussion for later. So, Aamod, you seem to be willing to talk.
Thank you, Bertrand, and thank you for the presentation. And this is probably the first time I'm looking at the kind of data that analyzes insurance claims. So I had a few questions first about the nature of data that you use, if I may. So okay, hold on, please. Let's use my English. Okay, some notifications are coming. So what I was trying to ask is, are these claims data from private ROG hospitals, or
it's all the hospitals, government and private.
Okay, and usually the claims data, they're from tertiary hospitals. So I'm assuming that they are district capitals where people are traveling to in order to avail services.
Well, what's interesting in analyzing those claims is that you realize that many government hospitals or even private level hospitals that are registered in the scheme and that are supposed to offer therapies, the different group of therapies, not all the hospitals can provide or are accepting the schemes to cover them. They are bypassed actually, and there are a lot of districts in Andhra Pradesh and Telangana alike, where basically you have sometimes 1/3 or half of the local patients who are not getting treated from the district itself. And again, for the people to understand, a district in India, it's big, it's millions of people living there, and it's not something small, right? So right. It's indicative that there are some weaknesses in the local health system. And you're right also to point that we are looking here only in the frame of that scheme at the hospital services. So it's also a bit narrow in a way. But it's also, I think, very enlightening on what's really happening. And the focus also of these programs on the hospital sector, where actually the needs are more often on, ambulatory care or, primary care level.
Yeah, you're right. And this kind of spatial inequality is visible all over India, especially I come from the eastern part of India and from Bihar. So as it was apparent in your data that the coverage is extremely poor in Bihar.
Yeah, one of the issue. Sorry, I will just address your point right away. But one of the issue we have at the moment, even right now, 2024, these were all data that I collected myself, through web scraping and accessing different government websites. Even at the moment, we are trying to update our data and have more recent, data on the claims. And we put up RTI, we got in touch with the officials from those different programs in Telangana and Andhra Pradesh, and it's impossible to get the data. While we know the data has been collected and it's been, the curation of data is better. We know this, we have seen it, but there are a lot of national initiatives also to allegedly help us to access, this type of data, even for the PMJ program and all this. And it's a maze. Like, you know, we cannot get there. We cannot access the type of data we want yet. And so again, we're talking about globalization, what's going on now, and all the talk about data and how it's going to, you know, produce better policies or better analysis. And actually, it's a struggle.
Yeah, thank you for pointing that out, because as a researcher, we face a lot of these issues, especially collecting data. My question before this was, is the spatial inequality also in a way explained by the fact that health policy or health is a state subject in India, which means the individual provinces decide how to organize their healthcare policy.
Aamod, I'm sorry to interrupt. It's just that I was suggesting to do rather the presentations now and the discussion
okay,
after,
sorry.
because I have a technical issue and might get disconnected before the end of this panel.
Sorry, yeah. So
I thought that
okay,
you were
then I'll
going to
start with.
present your work. Exactly.
Okay, sorry.
But I'm sorry
Sorry.
because the discussion will be interesting anyway. It's just
Okay. So I'll be doing a verbal presentation, and I'll be doing it in two parts. First is a general, basically an overview of how globalization, especially in context of the pharmaceutical industry, especially neoliberal globalization, changed the content and character of the pharmaceutical industry. And just an aside from that very fact, I'm right now in a place in northern Bihar, and if you look at the social indicators of the place, physically, if you look at the place, this place looks like it's lost in time, in a sense, in a very orientalist perspective. And as we know from the history of Indian globalization, that markets opened in 1990s in India. So you would think that the fruits of globalization have arrived in this place very recently. And yet I was surprised to know that nearly 250 years ago, more than 250 years ago, a military adventurer from Strasbourg was employed by the local military governor to train his troops on European style, European military techniques. So it's not as if globalization is happening, especially in a site like India. Now it's been a place where there are many intersections, and even in remote corners of India like this, the effects of globalization can be seen even if it's not very apparent. When it comes to just a short description of how globalization changed the Indian pharmaceutical industry, before the 1990s and India accepting the TRIPS agreement, World Trade Organization agreements on patents, which happened in 2005, India had its own domestic patent law, which was passed in 1970, which did a remarkable thing, which was to award process patents rather than product patents for drugs that are made in India, which led to a lot of reverse engineering happening and growth of the generics industry in India, which essentially led to India being dubbed the pharmacy of the world, so to speak. And Indian producers were able to produce generics and supply to many different countries in the global south. In 2005, after India signed the WTO TRIPS agreement, this previous law was amended, and product patents were now being awarded in the Indian market, which have now led to a lot of flourishing of the industry, a lot of foreign investment in the industry, but it has also led to increase in drug prices. And however, there were certain protections made even within that agreement to ensure that domestic pharmaceutical industry is protected. One of the key things were a provision to ensure that evergreening of patents was stopped in Indian market. So that provision was made especially to protect generics. But it still has had a lot of negative impact, some positive, but a lot of negative impact on affordability of medicine prices within Indian markets and in Indian public health care system. Coming back to my own work, right now my PhD thesis is studying the circulation of a emergency humanitarian nutrition palliative called ready-to-use therapeutic food, which was developed by a French pediatrician in Africa to effectively cure and solve the problem of severe acute malnutrition and early mortality in children affected from severe acute mortality, which is a very acute condition of malnutrition that is usually presented in places where there are famines or civilian emergencies or anything that rapidly cuts off the supply of food and clean water to a population. So essentially, in all these disaster conditions, wherever large multilateral organizations like UNICEF and Médecins Sans Frontières work, so RUTF was developed as a hybrid between food and medicine, sort of gray area between these two, that is being given to children. And what RUTF did and what it claims to do is essentially solve a lot of logistical issues that existed in earlier programs, earlier vertical malnutrition management programs. And it really simplified the logistics, organizing the logistics of malnutrition management. And it really sort of boiled down all these medical, clinical interventions and socio-political interventions into one small sachet of peanut butter, essentially, that was given to children and that they can eat within their communities in places where there are the local healthcare systems, local social security apparatuses have sort of completely broken down. In these places, this medicine can be used, not medicine, but this food product can be used to treat children with severe acute malnutrition. Now, my research involves looking at where India comes as a site comes into play within this chain of events that creates an international sort of standing reserve of emergency malnutrition palliative. And what we see is that India serves as a very crucial site for production of RUTF. And one of the largest users of this kind of products are actually in other global south countries, in many African countries, as well as in other South Asian countries as well. And hence, what we see is India serving as a site in the long intercontinental chain of creating emergency malnutrition products and supplying it for the global markets, where essentially peanut produced in western part of India will probably end up in being served in a malnutrition program somewhere in Africa. And what I'm trying to look at is how within the Indian context, within the Indian policy space, how is this intervention seen? How are the ideas about malnutrition and how are the ideas about RUTF in particular debated within the Indian policy context? And what we see is that RUTF is being debated in a way that challenges the existing notion of transnational NGO overreach of these big organizations that promote RUTF. And moving forward, as we will probably discuss this in more detail, but I think I should, since we are a bit short on time, I'll stop with my assertion that this is definitely a product of globalization, that emergency medicine that is being used in Africa is being procured from India, but it has interesting lessons for how we imagine contemporary humanitarianism. And yeah, so I'll stop myself from here and then we'll probably discuss more as time comes. Thank you.
Thank you, Aamod. So I didn't want to pressure at all, and there is a good news, which is at least, which is that Bertrand just added a lot of gigabytes on my Airtel prepaid abonnement, and so now I'm good. So we can have this session like in a better way. So,
Okay.
but since you stopped, it's fine. Like, and I think like the idea will also be to discuss in the end about the relations in between maybe global trends in your both presentations, and I'm almost certain that Victor will also ring a bell in a way. So, but since you stopped, I think it's nice if Victor can say a few words if he's still behind his computer right now. Victor, tu nous en... Ouais, ok. And then we can have a discussion trying to find the entanglements in between your presentations.
D'accord, bonjour. Ouais. Et est-ce que je ne sais pas qu'est-ce que je dois faire parce que j'ai une présentation en espagnol. Et donc, et, euh, et donc mais peut-être que je peux essayer de montrer les slides en espagnol et faire une petite traduction en français. Et peut-être de cette manière, on pourra comprendre un petit peu plus.
Let's try. Là,
Ça
donc,
marche?
comme tu vois, il y a... Donc, moi, je parle pas espagnol.
Oui.
Aamod ne parle pas français. Et bon, après, on verra. On va ajuster. Oui. On est très habitué à faire de la traduction plus ou moins simultanée. Donc, c'est pas un problème. On est entre nous. Donc, présente comme tu veux présenter.
D'accord, bon, ça marche. Et
So just Aamod, one mod, like, so Victor will present in French. You'll see his slides, and then we can also try to exchange in translating.
Okay. And
And
apologies for
just
not
and
knowing
just so
French
that you
and
know, like Victor was a PhD student of Maurice Cassier, just to
okay.
connect the dots.
Yeah. Okay.
Ah, d'accord.
Sure.
Et donc ce travail, ça fait partie de la question sur l'histoire des politiques sanitaires en Colombie, mais toujours en rapport avec la mise en place d'une industrie des médicaments et des vaccins pendant le XXe siècle. Et ce projet fait partie de cette initiative de Magie, de Koichi Kameda, qui sont en train d'analyser les innovations des pays comme le Brésil, la Colombie ou l'Inde. Et donc, j'essaie un peu d'intégrer dans leur travail la perspective historique. Et donc, c'est un peu la question que je voulais poser dans ce travail. Et on a un point de départ de l'actualité, que c'est que maintenant, on a une sorte de constellation de production de vaccins et de médicaments. Et du coup, après la pandémie COVID-19, les gouvernements, mais aussi les industriels du secteur privé, ont commencé à s'engager très fortement dans la mise en place de différentes initiatives de production de vaccins et de médicaments. Et donc là, on a les noms un peu des entreprises comme Bogotá Bio, qu'il s'agit d'une entreprise qui va commencer à fonctionner dans quelques mois. Ils sont en train de s'organiser, de mettre en place et de construire une plante de production à Bogotá. Mais cette entreprise travaille, elle fait partie de le secteur public qui fait un joint venture avec Sinovac de Chine. Et donc, l'entreprise chinoise va faire la transférence de la technologie, va aider aussi avec pas mal d'argent et les gouvernements municipaux de Bogotá mettre un petit peu plus de ressources pour développer la production de vaccins en Colombie, à Bogotá surtout. Et après, il y a d'autres initiatives comme École, Institut national de santé, qui vont produire des vaccins pour les campagnes de vaccination pour les enfants surtout. Et après, il y a une autre initiative qui se trouve à Medellín, que c'est une initiative privée qui s'appelle Baxtera, qui travaille aussi avec l'Université de Wisconsin aux États-Unis. Et là, ça fait partie des secteurs privés qui sont en train de s'organiser avec pas mal de ressources et avec pas mal de privés aussi. Et après, il y a d'autres secteurs publics comme l'Université d'Antioquia qui a une fac de chimie pharmaceutique qui ont un petit plante de production de médicaments. Et du coup, ils sont en train d'élargir ces plantes et ça va changer la donne pour les années suivantes parce que du coup, on va avoir une certaine capacité de production de médicaments en Colombie et ça c'est très intéressant. Donc, à partir de cette constellation de production, je voulais me demander qu'est-ce qui s'est passé pendant le XXe siècle et penser s'il y a eu des autres initiatives comme ça pendant le XXe siècle. Et donc, on trouve que mon hypothèse là-dessus, c'est surtout que quand on regarde l'histoire du XXe et XXIe siècle, euh, il y a eu une grande différence entre la Colombie et d'autres pays du sud global, que c'est que l'État colombien a eu un engagement assez timide par rapport à la production publique des médicaments et vaccins. Donc, elle s'engage dans des petits projets et surtout, il y a l'idée dans l'État et dans les élites que la participation du marché, ça doit être la participation du marché, c'est surtout quelque chose qui appartient naturellement au secteur privé. C'est un peu, à mon avis, c'est un peu l'idéologie libérale qui pense que l'État doit être toujours en restreint de ce genre d'initiative. Donc, quand l'État essaye de faire quelque chose et de s'engager dans la production, le fait dans des projets très timides et surtout qui changent ou s'arrêtent après quelques gouvernements, avec les gouvernements qui changent aussi. Donc, il y a une certaine timidité du gouvernement face à l'engagement de la production. Et donc, pour aller vite, parce que je n'ai pas trop le temps, j'ai deux exemples de ce genre d'initiative. La première, c'est l'histoire du laboratoire Samper Martinez qui se développe un peu entre les années 1920 et 1950. Et donc, on trouve là une initiative très intéressante de la part de l'État qui va fournir des vaccins et de certains médicaments pour les pays. Et puis, il y a une autre initiative après les années 48, pendant la décennie 1950, et qui s'arrête surtout à 1980, que c'est une sorte de petits laboratoires pharmaceutiques qui vont fournir les marchés colombiens et dans lesquels il y avait de la participation de l'État. Donc, comme les premières initiatives, c'est le laboratoire Samper Martinez qui a été fondé en 1917 par deux médecins qui faisaient ces études de spécialisation en médecine tropicale dans les écoles, dans l'école de médecine tropicale de Londres. Ils se sont réunis là-bas, ils se sont rencontrés là-bas. Et puis, à son retour en Colombie, ils ont dit, bon, on va mettre en place un petit laboratoire de production, un petit laboratoire de diagnostic. Et c'est comme ça qu'ils ont commencé à Bogotá. Cette petite entreprise qui, grâce à son succès, quelques années après, ça veut dire en 1925, l'État colombien s'intéresse à les racheter et il les fera avec de l'argent qui a donné en coopération la Fondation Rockefeller, qui était dans ce moment-là très intéressée dans l'élargissement de la santé publique en Amérique latine et d'autres pays du monde aussi. Donc, avec cette coopération avec la Fondation Rockefeller, qui se faisait avec du budget, avec de la transférence de technologie, avec la formation des experts colombiens qui sont allés aux États-Unis et après ils sont revenus pour travailler dans cette institution. l'État colombien s'est fourni, a été capable de se fournir une capacité de production de vaccins et ça a été très importante, surtout pendant la première moitié du XXe siècle, mais ce laboratoire va changer, il va devenir l'Institut national de santé qui existe encore et qui contrôle, commande, pilote et fait le pilotage de la santé publique en Colombie. Donc, ça, c'est une initiative assez réussie de ce genre de production locale. Ok, bon, je passe là-dessus parce que je vais pas rester beaucoup de temps sur ce sujet. Et après, il faut dire que à partir des années 80-90, il y a eu un processus de désindustrialisation du pays et dans le secteur de la production du vaccin. Donc, dans cette institution San Martínez, qui s'appelait déjà Institut national de santé, au lieu de faire la modernisation des équipements, cette institution fait le choix d'arrêter la production et commencer à faire de la importation de produits. Et donc, du coup, à partir de l'année 2000, la Colombie s'est trouvée, si pendant des décennies, on avait été capable de produire, par exemple, la vaccine contre la fièvre jaune, du coup, il fallait la importer du Brésil ou des États-Unis. Donc, on se trouve un peu dans ces conditions. Et c'est maintenant que le gouvernement encourage l'Institut national de santé pour qu'il mette en place à nouveau cette capacité de production. Donc, on est là un peu. Et après, il y a eu d'autres petites initiatives dans les années 80, dans les années 40 et 60 du XXe siècle, des petites productions dans la ville de Bogotá, des petites institutions liées à, à la, à l'assurance maladie et ils ont été capables de fabriquer quelques médicaments, mais qu'ils ont eu pas mal de problèmes de contrôle de qualité. Mais quand même, c'était des petites initiatives du gouvernement, des gouvernements locaux pour garantir la production de médicaments locaux. Et après, je crois que l'initiative la plus intéressante dans les années 60, c'était, ça venait du parti d'un médecin, deux médecins, José Félix Patiño et Santiago Rengifo, des médecins qui ont travaillé aux États-Unis avant de commencer à travailler avec le ministère de la Santé en Colombie. Et donc, d'une certaine façon, ils ont regardé les modèles de certains États dans les États-Unis où il y avait de la production étatique des médicaments génériques, ou au moins il y avait de l'encouragement de l'État pour que la concurrence dans les marchés des médicaments se mette en place. Et donc, dans les années 60, ça sera ces deux médecins, José Félix Patiño et Santiago Rengifo, qui vont encourager l'État, encourager les marchés pour mettre en place un marché des médicaments génériques avec de la production locale et surtout avec une joint venture entre une entreprise pharmaceutique américaine et une entreprise colombienne. De cette manière, l'État mettre en place une politique qui va encourager la concurrence dans les marchés et l'arrivée ou l'émergence du marché des médicaments génériques. Donc, ça, c'est l'autre grande initiative du XXe siècle qui a duré au moins jusqu'aux années 80. Cependant, je crois que je suis encore dans le temps. Cependant, il y a un autre acteur, que c'est l'industrie pharmaceutique traditionnelle, qui a, qui a des brevets, qui a une grande reconnaissance internationale. Et du coup, cette industrie pharmaceutique et ces fédérations ont commencé à s'opposer à ces projets ces politiques pharmaceutiques nationales. Et donc, l'État doit dénoncer un peu les sabotages de ce genre d'industrie sur les marchés des médicaments génériques. Et c'est ça qui est à la une du journal dans cette slide-là. Et donc, pour conclure, je voudrais poser la question que c'est quel est le rôle de l'État dans la post-pandémie. Et donc, le rôle, ça sera d'encourager l'industrie privée, la production publique, ou faire une sorte pour que les deux puissent avoir une capacité de production importante. Et après, ce qu'on voit avec cette constellation de laquelle j'ai parlé tout à l'heure, c'est une sorte de géographie pharmaceutique en réorganisation. Parce que normalement, c'était Bogotá, la capitale du pays, la ville dans laquelle on trouvait ce genre d'industrie. Et du coup, maintenant, on trouve qu'il y a d'autres villes, des villes comme Medellín, qui commencent à avoir cette capacité de production. Donc, il y a une géographie pharmaceutique qui change un petit peu. Et surtout qu'il s'agit aussi de changer la logique normale on attend l'innovation dans le nord pour l'approprier dans le sud. Du coup, là, on trouve des initiatives sud et sud-sud, par exemple, l'entreprise Bogotá Bio et Chine, et la Chine avec Sinovac. Donc là, on a ce genre de géographie pharmaceutique en réorganisation. Et l'autre point à souligner, c'est que c'est très important avec cette histoire qu'on regarde au XXe et XXe siècle, c'est c'est très important qu'il y a une politique de la part du gouvernement qui puisse garder et garder pendant le temps et d'empêcher qu'avec les changements du gouvernement, ce genre de politique s'arrête. Donc, et finalement, c'est très important d'améliorer l'engagement, le travail entre les divers acteurs pour encourager la production, mais aussi mettre en place des montages juridiques qui permettent de garantir la gouvernance et le contrôle du secteur public dans les entreprises qui sont mixtes ou dans les entreprises qui ont ce genre de participation de l'État. Donc, c'est pour l'instant et dans cet état qui se trouve mon travail de recherche. Merci beaucoup.
Merci beaucoup, Victor. So I'll switch a bit to English for the discussion, but like you can answer in whatever language you deem appropriate. Maybe one first question would kind of take us also back to Bertrand, but it's just that I found it very interesting in your three presentations, the fact that you are kind of peopling the production of health and of population's health through a series of devices, be it the health coverage, the products that are needed. And so we can see, like Bertrand has also been talking about the infrastructuring aspects of it. There is just one I mean, not only one, but at least one very important actor that has been pretty absent from the discussion. And it's the hospital and the role of hospitals and the evolution in this process. And I was particularly thinking about this in the case of Bertrand, because I know you have a lot to say about this shift in between how is the UHC in particular playing a role in the shifts or movements or oscillations in between private and public? Who benefited? What are the kind of arrangements? I mean, like there's a whole series of questions, and I know you at least partly addressed a lot of them.
I could talk at length about this issue because I think there is an historical depth to it. Like when I started to take an interest in the hospital sector in India in the early 2000s, there were a lot of debate around basically the privatization of the healthcare system in India, the rise of the private hospital sector in India, and how globalization was instrumental into it. It's like we had almost two schools of thoughts on it. We had on one side colleagues from GNU, colleagues from certain political background, leftist, Marxist background, structuralist background, who were explaining things in terms of, all right, 1991. Liberalization kicking in India, the opening of the country, and then privatization is coming in a strong way and transforming the healthcare system. And then we had, of course, other researchers or other experts, sometimes also with strong, and again, you are all in STS and all this, with strong roots. You might say in the US, academic system with Harvard and so on, and that was all about how we're gonna make the privatization work for everyone, and that was the PPPs, and that was all these things that were pushed forward with the support of the World Bank. So this interaction between and when I came into it, I was thinking about all those things as a geographer, as with a different background and perspective. I was like, okay, these are all interesting, but that doesn't tell us really what's happening on the ground. And you had work from for example, Rama Baru, who's professor of sociology at GNU. There were a few works here and there that were really giving us a sort of a bottom-up perspective to it. And if you return to the history, privatization of the hospital sector is as old as colonization. When the British came, they brought some doctors from England, UK, British Empire, and they allowed them to open up their private clinic. So they were working, for the East India Company, and they were allowed for private practice. And then we had also local traders communities in the middle of 19th century in Bombay, who opened up private hospitals for their own community. So privatization is a very long, phenomenon in India and South Asia, maybe more generally speaking. And so my approach is like to say, this last phase we have, the UHC and all this, we can draw parallel there with what happened in the US in the 60s. Kennedy, all those years, you had the Medicaid program, the Medicare program that was meant using federal fundings to help and improve the access, particularly for poor communities, Afro-American communities who were left behind and had very poor access to hospital services. And so government funds are kicking in, and particularly in southern states of US, and they help the growth of private groups, hospital groups. And you might say that there's something similar happening in India over several decades. From the 90s, from even the 80s, we see a government support for many private hospital groups or private hospital operators. And the UHC is just the last chapter, and much more funds now are available for the private sector in that sense. But there's no reciprocity in the sense that the government is not really smart in using it as a leverage to really, improve fully the access, improve the quality of services, which is really lacking in India, the lack of control on what's really happening in hospitals. There was, again, a few weeks ago, a horrible fire happening in a government hospitals, but that gives you a broader picture of, the state of disarray of the hospital sector. So, yeah, I'll stop there. We have a lot of things to talk about. Yeah.
No, it's just, and also because when you were talking about Kennedy's politics, and there is a whole discourse that got built and supported in the 70s on the primary health, but today it seems that these primary health centers and politics have been put in place, but today I guess once again I don't know much about this, but in the process it seems that the universal coverage is of course not dedicated, not to benefit to these infrastructures that were pre-existing and that are either you were using lagging behind, or that kind of set aside of the current move. And I completely get you when you're saying that it's not maybe so much a matter of privatization, because privatization has always been existing in a way, and it's a movement. It's also about who benefits from this kind of policies, and beyond there are the patients should be the one benefiting first, but then there is a lot of a whole series of interest that pre-exists. But it was just
no. Many hospitals, like we talk about the Arrow-Free program in Andhra Pradesh, Telangana, they've been constantly sort of feared and bargaining between the private hospitals and the government. Private hospitals saying, look, we are taking our share there, we contribute to the program, we are part of it, but you have to increase the level of reimbursement. The pricing you are giving us is not at all accurate anymore. It needs to be updated. And so it's becoming,
And Aamod wanted to say something, and maybe after we could also listen to Victor's opinion on the link. Victor, en fait, dans ce que toi tu as regardé dans l'histoire des politiques de médicaments, ça m'aurait aussi intéressé de savoir le rôle qui est attribué en fait aux hôpitaux comme lieu de diffusion, comme lieu de... Est-ce que tu vois un lien? Parce qu'il y a les travaux que tu as menés, l'ensemble des travaux, c'est l'industrie, c'est à ce niveau-là, mais en fait, il y a aussi tout le niveau de la diffusion, la pharmacie, les pharmacies d'hôpitaux, les hôpitaux eux-mêmes. And so I would be interested also to listen to your take on this, the link in between manufacturing pharmaceuticals and policies. And but first, maybe Aamod, if you wanted to say something, I don't know.
Yeah, thank you. Just to add to what Bertrand said, I think post 90s, it was more a corporatization of health rather than just privatization, because as he explained, privatization has been happening. And just a little bit context to that also. Healthcare system, especially government funded healthcare system, also has some colonial linkages to it, because essentially organized healthcare in terms of hospitals started really as a colonial enterprise to protect British troops in India from the dangers of the tropics. So that's the reason why even today, and you can see the remnants of all these government hospitals. You can still see in many cities today that the hospitals, big hospitals, are in the civil lines, for example. And that's because they were the old British quarters where the hospitals were located. And this kind of publicly as in funded by the colonial government, hospitals were not really very accessible to the general public. And especially, I know that in, for example, places like Kolkata and Eastern India, there were many private individuals who came up to construct private hospitals, teaching hospitals, as well as practices to sort of plug that gap and cater to that need. So it also has a certain colonial background to it as well. Yeah, just to add that, and yeah, I agree to whatever Bertrand said. Yeah, please.
Maybe Victor, and I can see that la relève est arrivée, so I don't know if we will have so much time to chat.
Non, mais, je ne sais pas si maintenant les hôpitaux sont en capacité de faire ce genre de production, mais il y a au moins l'expérience de l'hôpital San Juan de Dios à Bogotá, que c'était un des hôpitaux les plus importants du pays, qui avait des capacités de recherche, qui avait une grande, qui offrait des services de santé à une grande couche de la population de Bogotá. Et donc, au siège de l'hôpital San Juan de Dios, a été mis en place un laboratoire de production pharmaceutique à partir des années 40, 50 et a duré jusqu'aux années 90. Et maintenant, il y a aussi les projets, parce que l'hôpital San Juan de Dios est fermé, et donc le gouvernement actuel a les projets de rouvrir l'hôpital, mais aussi ce petit laboratoire qui avait une capacité importante, surtout pour fournir des médicaments à l'assurance maladie. Donc, on a déjà cette expérience et voilà. Mais
Je pensais même pas aux hôpitaux comme lieu de fabrication, enfin pas seulement, mais même comme lieu de diffusion, comment leur rôle, en fait, il est intégré dans ces politiques. Je pense par exemple que dans une enquête il y a quelques années au Bihar en Inde, donc un des États indiens où il y a souvent beaucoup de problèmes disons, de dysfonctionnement administratif, quoi. En fait, l'hôpital est un lieu dans lequel doivent se trouver un certain nombre de médicaments de la liste des médicaments essentiels. À l'époque, il n'y en avait aucun. Et en fait, il y a une politique avec une politique de médicaments essentiels, mais après, il y a des fonctionnements qui font que, selon les périodes de crise, sont plus ou moins longues ou continues, pérennes. En fait, il y a des moments où, en réalité, ces hôpitaux n'assurent pas du tout ce travail parce que tout le travail de diffusion est aussi délégué implicitement au secteur privé, et en premier lieu aux pharmacies. Mais je pensais à ce genre comment est-ce que ce genre de dilemme, il est aussi affronté par les pouvoirs publics quand ils construisent des politiques pharmaceutiques. Les politiques pharmaceutiques, c'est pas seulement le manufacturing, innovation, c'est aussi tout ce qui est la logistique, la distribution, comment on rend ces médicaments accessibles, quoi. Je pensais un peu à ça.
d'accord. Ah, c'est une question très intéressante et il faudra regarder.
Très bien. So I guess it's time now. And also I saw that for Victor, it's very, very late for you now. It's 12
Yeah.
at night.
C'est minuit, oui. Je
Ouais.
dois travailler demain.
So thank you very much. I mean, it was easier for the South Asian side of it because it's only a beginning of the day, so it's fine. But thank you very much for the three of you, and I hope we'll have other opportunities to cross views on this because I guess it was a very interesting discussion to have. So thank you very much.